So, this is the case of yesterday. This is 70 years old male with a typical angina for a Westman that was accelerated with risk factor arterial hypertension. Nothing special from the ECG, left ventricular hypertrophy. The echo is with 54 ejection fraction percent, hypokinesia of inferior wall, infralateral basal and mid segment, and anterior wall, mild to moderate mitral and tricuspid regurgitation. We did angiography, let's say about 7 to 10 days before today, or let's say yesterday, and you can appreciate that he is there is a three-vessel disease. This is distal left main, mainly ostium of AOD, subtotal occlusion of the circ just before the bifurcation of a marginal, which is a quite reasonable vessel. And there is some diffuse disease distally. The right coronary, artery is diseased. There was something at the ostium, but for sure it is not well seen here, but in one of the projections you can see that when you stop the movie just when the diagnostic catheter was out, there is probably at least 50% stenosis. And yesterday the patient presented with some chest pain, elevated troponins up to 1,500. And what we found on this right coronary is that the disease is, in my view, the stenosis in the right coronary was much more severe. So we decided to go for the intervention. Before that, the patient was, the right image is from yesterday. The patient has a syntax score more than 33, but the patient absolutely refuses cardiac surgery. And that's why we planned him for the event, for percutaneous revascularization. This is the story that I told you in brief. First of all, we went for femoral access. We went for the right coronary. It was not that easy because this right coronary is ectopic and it is a little bit anterior and higher. Finally, we cannulated this lesion and started predilated with 2 elbow wounds. After that, 275. And the last place, this was a scoring balloon just to modify the lesion. And then we implanted a drug-eluting stent, 3.5 by 22, a little bit longer because of the not very well suited guiding catheter. We inflated it, post-dilated it with 3.5. This is the final result of the right coronary, which I think is quite acceptable. Then we moved to the left coronary. We started with, this is EBU 3.0 and 7 French, put a wire into the AOD. First we tried to go with the regular wire. This is the run through this lesion, but it was not possible. Then we exchanged with, added a microcatheter, and even with the support of the microcatheter fine cross, it was not possible. And we finally succeeded to went through the lesion with the Gaia 1. It was not that easily. There was a need for some drilling. And the issue is that we did not have a clear idea where is the wire, but it seems that it is in the right place because passing with the wire just diminished the flow through this vessel. It was not easy to predilate. I started with 1.2 balloon. That was not possible to cross. It did not cross the lesion. After that, happily, 1.05 millimeter Ruray balloon crossed the lesion, and we did a post-dilation. What we did is standing from with 225 of the CTO and the proximal stand 2.5 up to the proximal part. In my view, and that's what we decided, the osteo of the circ seems not that diseased. There is a lesion here, which is about 5%, but finally when we put these stents, we decided to go to a provisional stenting for the left main to the from the left main to the AOD, and after that decide what to do with the proximal part of the circumflex artery. Predilation of the osteo-AOD with the 270.5 bone, and this is a stent which is 3.5 by 30. This is, you can see it in this position, aerocranial, just putting it the ostium part of the vessel. We inflated the stent. There was some pinching of this lesion, but as we suggested, it was probably spasmated because it was after that disappeared and is looking much better. 3.5 with NC bone into the AOD and posterior AOD pot with 4.0 bone. Final kiss with 2.5 and 3.5, and finally this was the final result after repeated pot. This was the result after stenting, and we decided that this is enough for the patient. This is divot that we made, and you can see the run from the distal AOD, which is quite diseased. We have a minimal stented area. It is not well seen, but it is far above around 7 square centimeters here, and roughly 9 square centimeters in the left main, which is quite acceptable as a result according to us. And this is the case that we did yesterday.
An excellent case, quite complex. With excellent result. Yeah. Any questions?
I think it was a good idea to keep to the provisional because finally we were able to make it a little bit more simple. Otherwise, anyways, we were ready to go for a tap that will solve the problem if necessary.
For the left main was exactly conform with the result of EBC main. The lesion in the ostial circumflex is short, was not so tight, was not so. I think, as you have seen, presented at 3 years by David Eldrick-Smith. It's in favor of single stenting in front of double stenting.
I have one question. Did you check the result in circumflex stent, the marginal branch stent, because you had some problems with the predilation, a lot of dilatation there, and probably it's quite calcified?
Yes, it was quite calcified. What we did is we put a 225 stent distally and 2.5, and after that we post-dilated, of course, to a very high pressure with 2.5 distally and 2.5 non-compliant bone just at the bifurcation with the circum, this big marginal. We didn't insist with doing a NIVAS because it is not always easy to go there, and there is a lesion. And let's not forget that there is a gap between the stent in the left main and the proximal stent. And it is not well seen here, but the stent was very well conformed after the kissing bone. What usually Yves says, we have covered the ostium and the most vulnerable part of the bifurcation. I mean, this is across not in the carina part, but the side of the bifurcation. So I think it's quite acceptable result. And we should keep in mind that there is the contrast volume, which is not that less in this case, especially doing. So we are moving to the CAD lab. Before that, Dr. Nanef will present the case, the last case.
Let me present the last case. It's about a 51-year-old male patient with high-grade stable angina, with risk factors, hypertension, dyslipidemia, and he's a smoker. In the past, he was with Hodgkin disease, and chest radiotherapy was performed. October 2023, he was admitted in another hospital with myocardial infarction, inferolateral, and also with acute kidney injury. He was treated conservatively. From ECG now, we have sinus rhythm with diffuse ST depressions. From echo, preserved left ventricular function with inferior hypokinesia and inferolateral akinesia. We performed dopamine stress echo with no viability in the 3 lateral segments, but also inducible ischemia in 7 segments. First, in anterior wall, and after that, inferior and anterolateral wall. Here is the angio. You can see the severe stenosis in the circumflex artery, proximal and distal, and proximal LAD. You can see second diagonal branch with slow flow, severe calcinosis, and severe tight lesion. This is the right coronary artery with some osteal stenosis. This is the case.
Добри, чувате ли ни? Can you hear us?
Hello, everybody.
It is loud by your side.
Пуснете си тая. Айде да снимаме сега, само че само да мине 1 минута.
Добри.
Да. Hello. How are you?
Fine.
Nice to hear you. Okay, so I will show you what we already made. So we are with the transfemoral approach, 7 French, right femoral. This is the right coronary. At the ostium there is around 50% lesion, which seems borderline significant, but and that was the reason that we made several projections, but this did not make the situation more clear. And this is why, as we discussed before, we made an non-hyperemic assessment for this lesion. And the RFR at this point, the lowest RFR at this point was 0.97, 0.98. After that, we made a pullback, just to be sure that this is the pullback, and there was a perfect one, and we decided not to do anything more on this artery. It is highly calcified, diseased at the proximal segment, huge artery, more than 4 millimeters, but functionally non-significant. We made the RFR twice. The first one was at the middle of the artery, below the healthy segment, and but the result was the same. After doing these projections, actually I was not surprised, because the minimal lumen diameter which we recorded is more than the outer diameter of the guiding catheter. This is a 7 French Judkins right guiding catheter, which means that the minimal lumen diameter in all the projections is more than 2 millimeters, and that explains why there is no pressure drop in this segment. So next we moved to the left coronary. Sorry. And this is the left coronary system. The circumflex artery is highly diseased, with the long tight stenosis at the proximal and distal segment, with around 2.2 millimeters obtuse marginal branch, and tight stenosis on the LAD, which was the double railway in all projections in the proximal LAD. There is also a disease segment in the mid-LAD, in the bifurcation with this moderately sized second diagonal branch. This is the spider view, and actually that was third diagonal. There is the first one, second small, very small, and third diagonal branch. This is the spider which demonstrated the stenosis on the circumflex, proximal circumflex, and distal circumflex. So we decided to do IVUS. We made IVUS several times in different segments. And we made IVUS in the LAD, and we made IVUS in the circumflex. It was a little bit difficult to introduce IVUS, and the results from IVUS, Eva will show you. She is now our IVUS woman for this session. So she is behind me. Oops. Just to keep the suspense. So we are...
This is the IVUS from the LAD, distal to proximal. You see?
No. Dobry is just in front of the camera.
Sorry.
Okay, so we're going to start again. I think that it is. This is the distal LAD and automatical pullback. And you see the bifurcation close to the first bifurcation distal, and the calcium is one-sided. And then proximally, this is the smallest one, and you see
At
the
the
circular.
bifurcation, yes, there is a 360 circle of calcium, which is quite long, more than 5 millimeters.
this is the aneurysmatical part, and then we have a severe lesion proximally with a 360 degrees of calcium.
This is LAD.
This is LAD, yeah, here. And the minimal lumen area is 2.7. This is,
Can we go back to the most calcified and severe stenosis on IVUS?
okay? We go back. Here. Maybe I'll remove the measurement.
Actually, this is the Eva measured here the calcium to calcium area, but actually the stenosis is so tight that it actually it's catched the catheter, the IVUS catheter, and practically everything all around is around
No,
the
the issue,
catheter.
there is no comment because this is more than 270
Yes.
degrees for sure. The issue is that probably this calcium is not only superficial and it is deep.
I can a little bit
Because we
doubt
have-
about that because there are a lot
Anyway,
of just Valery.
Yeah.
There are several reverberations behind the calcium. And this is a clear mark that the calcium is only superficial. This is a very good demonstration about these reverberations which you see, these semicircles here, you see what you see, these are reverberations which are clear mark that the calcium is only here.
Because there is some tissue between the
Yes.
catheter and the calcium. But anyway, rotablation is an option. If it is not working, probably we have another tool, and this is the shock wave. I mean the lithotripsy. So
If you
that's a
want to
good demonstration of how how imaging is important to assess the vessel. Although, to tell you frankly, if we have on angio, you have calcium is well seen on both sides of the vessel. This is a good mark that this is a severe calcified vessel, and probably you should think of debulking strategy.
So this is the IVUS, just to show the IVUS from the circumflex. This is the distal.
I'm more
Marginal
interested in CIRC
and,
because on the angio it is not that convincing about the.
Yeah, just
Yes,
because we started.
we
with
had quite a significant discussion with Eva that I was that there is no significant calcium in circumflex.
you
There
see-
is.
Yeah, there is. Yeah.
But there is,
Obviously,
yes.
there is.
Unfortunately, there isn't. There is not only at the distal part, at the proximal part. Actually, there was two places with more than 5 millimeters length of calcium rings. So the next question was to do rotablation. It's good, but which vessel first?
And this is
Obviously,
proximal circumflex,
the both vessels are calcified, diseased.
And what is the osteo-LAD? I mean, do we
Yeah.
need to go for the left main?
No.
No.
It's completely
No.
healthy.
We have enough, but let's say relatively healthy
Yeah.
segment of the vessel.
We'll show you because we didn't reach this. This is, we'll see the proximal LAD. And there are calcium, but the vessel is, this is the bifurcation and this is the left main. And the minimal lumen area is above 6.
And this is another question about the effectiveness of rotablation in vessels which are quite big and with quite big women, because in this situation you have this wire biased and the rotablation is not that effective. But finally we have solutions and we'll see. And where you decided to start from CIRC, what I see?
Yes.
What is the result?
We'll see now.
The result, this is the rotablation. We made
This is 1.5.
yes. This is 1.5,
Full screen? Yeah.
and this is the result. Maybe we should make a better picture, just for the audience. Okay, so this is the result for the circumflex. And we should replace the result. I think is quite good. Do you see it? Valeri?
Yes. So we are going to exchange with the regular wire and continue with this vessel.
So your suggestion is to do only circumflex?
No, I mean, but
To fix the lesions and then switch to LED.
To fix the lesions and then to
and then go to the LED probably.
Sorry?
I mean, what I would do is just finish the CIRC, I mean, exchange the wire or whatever you prefer, predilate with a non-compliable wound and just stent it. And after that, go to the LED. Or depends, we can postpone the LED for another session, but
My only concern is the spider view. And the highly diseased ostium of the circumflex.
But what is the minimum lumen area at the ostium of the CIRC?
4.3.
4.3.
We don't have any issues then.
Yeah.
We know that if it is, and we are not going to, and you see, these vessels for sure is ectatic at this, after this stenosis, and the distal vessel is not that big. I mean, we have a big marginal, and relatively big circ, but I think a stent that can accommodate here about 275 up to 3 will do the job, even 2.5, because in my view, even the ostium is big, but it is not for
Okay.
always okay. It is not justified to think of going into the circ for, and after that into the left main, especially in this patient. Do you agree? What do you think?
Yeah, now I will do exactly the same as you, high pressure balloon. Even if
Good
maybe
for
it's not
Klopfenik.
as calcified as the LED, then the stent, we choose properly the lens to avoid to stent inside the aneurysm, because we will leave probably incorrect deployment of stent there, and after that move to LED. If you have shockwave, we change, and we try to you will avoid to do a rotablator both sides in the subsession, so which is normally not a problem.
Не, ние имаме 2,5. Не.
At the
Нещо ще ни
same
трябва за
time,
еладето,
it
ще
should
ни
be
трябва-
reasonable.
дай ми
We have
шприца с
the
вода.
rotoblade on the table,
Шприца
so
с
we can
вода.
do it. And what we have is experience with shockwave, because we don't have that much case, but probably there are about 50 or 60. Usually we need preparation of the lesion before the shockwave, and in about 40% of cases we are doing rotablation, and these are the recommendation of the producers,
We'll
because in
do
such calcium you can
sequentially,
destroy a wound that is almost 3,000 just passing it inside without doing the. It is fragile. It's a fragile device.
Добре, това е новия, който го бях в началото, нали? Имаме един нов. Okay, so we will do the vessels sequentially, circumflex, and then LAD.
But we are in a way not allowed to do a rotablation if we have the wire. And it is, for example, you can use in very
Мъничко само.
very specific scenarios
Се завре.
a gynae catheter extension just to cover and to protect the wire. But I think this is not the case. Just as a comment, what we are doing usually, we're using a fine cross just to go through the lesion, and after that put the rota where it
this
is much
is
more
faster.
easy and predictable. And after that, with the same fine cross, we exchange for the workhorse wire, yes. And,
So, добре. Добре.
I would just to remind
Okay.
what you see, the Bulgarian Society of Interventional Cardiology is organizing an annual meeting, scientific annual meeting. Can we show this slide? And it is on the 27th of April, and here we have it, and it will be held in Plovdiv University, where we have a very good facility. They have a special room with auditorium, something like this. So this is the first announcement, and just save the date to all of you. And very soon there will be the program that we're in a process of preparing. Just to what Dobry and board of the Interventional Cardiology Society decided is to, as a president, that was his initiative too, that is to make this meeting annually and to hold it on the, let's say, last Saturday of April, because I think that is important to have additional meeting each year, not only the biannual meeting of our Congress Interventional. Thank you. We can go to the room. So what kind of balloon already?
It's a regular semi-compliant, I think this is Solaris.
Semi-compliant, not
Yes,
non-com-
semi-compliant, 10. Yes, semi-com.
At low atmospheres.
10, 12, 15. Deflate.
What's the point to use a semi-compliant balloon in such a calcified lesion?
Because the balloon appeared on the table, but nice. Appeared on the table.
It's a volunteering balloon.
Yes, I set to 5 balloon anyway. And yes. And this is why the balloon flight magically on the table.
So it seems that it's opening quite well.
Exactly.
Very nice result.
Yes.
And now we can see that distally after the ectatic part of the vessel, there is, I think, no big stenosis. So we can focus only on the proximal critical lesion that was calcified.
But the burr stopped and has a lot of resistance after this aneurysmatic part.
Дайте ми някакъв стенд 2.5 на 48.
Or the other point for discussion is to use DCB in such a long calcified lesion well prepared.
Huh?
DCB.
DCB, in my view, is
DCB is viable option in this
For the
situation. Absolutely, you are absolutely right.
And the other point is that from the stress echo, the lateral wall is not viable.
The ejection fraction of this patient was normal, yes? It's 60%. 60% without viability of the lateral wall. 60% ejection fraction without viability of the lateral wall. I see that Dr. Stoyanov is laughing, smiling. It's good. Probably he understands my point of view.
I got it, but just for discussion.
So I think that
DCB?
this distinguished panel can discuss this point.
What do you think? Who will go for a DCB here, or you choose a regular drug-eluting stent?
Me.
Why not? Why not? But yeah, you have to for this. Well, that's a long one. So he will cover the aneurysm. Personally, I won't do that because you will leave a stent which cannot be apposed on the wall. So. And it's too distal. He has to go back close to the.
Test.
Maybe I will go probably for just a compromise, not a DCB, not only a balloon, but just a shorter stent in the proximal part. Probably.
I would like to ask you, don't you think it's a good idea not to cover the aneurysm with this stent? You can stand proximally, as Professor Geller said, and just leave it ballooning distally, because you have a lot of vessel behind the stent that is 2.5, and the vessel is ectatic at least 3.5. Do you think there's a needus for thrombus there in the future?
Кое? А нещо, таймера може ли да пуснем? Okay.
3 times 30 seconds. Your
I'm
balloon
following
is not open.
If advice, and we are waiting and waiting patiently. I hope that the
not so
patient,
long,
the
you know,
patient also will.
It's not so long.
Wait,
We can
bulk of
discuss with
гърдите имате ли?
you.
But he
Bulk
is
of гърдите?
retired and he has
Не.
plenty of time.
Yes, but you know, the 3 times 30 seconds
Deflate.
is following the paper of Thomas Ovas, my associate. He was doing the work in 2012, and he published in 2013. I will show a slide tomorrow. So
Дайте ми един
it means
обикновен,
that that's a long time that we are
балон.
doing a long
3 на-
inflation and several times.
3 на 10, 12, 15.
What we do routinely is after putting the stent, we always go for a non-compliant balloon. So this is something that can.
I don't see the reason why we inflate a non-compliant balloon in already stenting vessel, knowing that the nominal diameter in non-compliant balloon is 15 and more, and is never get the nominal if you inflate only one time. I can demonstrate that tomorrow if you want, or give you the literature. Put we are speaking of the same size of the balloon. Of course, if you use a bigger balloon to correct an unnecessary deployment, not a good deployment, you can use a bigger balloon because this with this non-compliant balloon. But if you put the same diameter, high pressure, non-compliant high pressure there, will do nothing, absolutely nothing, guaranteed.
I have a question about the stent, because it looks quite long. Can you share with us?
This is Science Pro Sierra.
2.5.
2.5 to 48.
Yeah, thank you.
And now
Science.
the balloon is 3.0 semicon.
Okay, let's make a picture. Film. But nice.
I mean, the rationale of using non-compliant bone, many years ago, there were some studies that were done, and they proved several things according to them. First is if you inflate the stent, there is malposition in, let's say, in almost 10 to 50% by angio, but more than 70% by IVUS. And after that, they did the same, putting the same balloon and putting the stent and inflating it with semi-compliant balloons, bigger balloons, and again there was a huge percentage of malposition. And this malposition was corrected and achieving a good minimal stented area after putting non-compliant balloons. And that's,
nice.
as far as I remember, this was one of the things that we should do, especially with drug-eluting stents, in order to have optimal results.
Yes, but I know this study, but the problem is not in the choice of the balloon. The problem is the way you use the balloon to deploy a stent. 5 seconds, I can prove it, 5 seconds cannot deploy your stent because, as I told already you, the first inflation is not reaching the nominal curve produced by the company. No. So you get the nominal curve only at the second inflation. And if you have, if you inflate 5 seconds, you will never go to the nominal.
No, you are absolutely right, because these nominal rates of the balloons are ex vivo, and they are not even in such tissue as a calcium, even in normal vessel. And that's why there is an issue that telling that the nominal, usually there is, I think, if I'm not mistaken, between 15 and 20% under expansion of the stent from the nominal, let's say, number which the producers are. That's why you should go and expand
you
it.
are nominal. First inflation you will never be.
With the nominal, you don't
Second
reach
inflation you maybe.
the predicted.
That's all. So if you use properly a semi-compliant balloon, you don't need a high pressure non-compliant balloon. And we have shown, we have got the result for bifurcation of October last year in EBC was discussed, and was of course greatly in favor of usage of OCT versus angio guidance. But the recommendation was 5 pages in the paper, 5 pages. Recommendation for guidance with angiography. Not a word on the plasticity of balloon, which means several inflation. On the time of inflation, absolutely nothing. So in the group of angiography guidance was unfair not to do that, you know. So this trial has to be done again. And the good news is that the trial was done again at a Korean group that randomized OCT or IVUS, OCT and IVUS to QCA guidance, and the trial is bigger than October, and the result is absolutely no difference. NS, nothing. So it's not published yet. It was presented only in Amsterdam, was not published yet. It's 1,300 patients randomized, more than October.
But the robust results that we have from imaging are not that promising, especially in OCT. What we could say is that they are almost the same, because they expected that OCT will have some advances compared to IVUS, but this didn't happen, in fact, in all these trials.
You have seen Illumin 4.
Illumin 4, yeah.
Illumin 4, how many patients randomized? 2,000 something? 300? Negative. This is related to the COVID. Yes, yes.
Yes, that's one of the explanations.
Yeah. But the idea proposed to explain that, because I'm sure that in Illumin 4, the angiography guidance group was not done better than in October. But what he explained is that during the second time period of occlusion, the formation of the operators was abandoned because they cannot move, they cannot. So this explains that the rules for usage of OCT were not followed. But in the opposite group, they had done nothing at all, because there was no teaching in the first period and no teaching in the second period. Yeah? So this is not a good reason. We have to use properly what we have, angio guidance and balloons. And stents.
So,
1,500 lumen, negative, imagine, the money. It's not impossible that we redo the October. Personally, I'm in favor of doing that. We have to find the money again.
Dobry?
Да. Yes, okay, so
This is, there is some.
we made an IVUS, and as usually, can I see, just give me live, just I want to see, okay, to see,
The ostium of the stent should be
yes,
a little
okay,
bit
here,
closed.
here is that, just to see where is that, okay,
This is the distal part,
okay,
this bifurcation.
yes, okay, okay. Another one is clear. Okay. Good. So Eva will show you. Then we won't wait it. Eva will show you the IVUS. There are two problematic places. The one is just around the bifurcation of this margin. Дайте ми 2,5 балона. The one is just the bifurcation and the proper circumflex and yes, the proper circumflex in this obtuse marginal branch.
Just
And another one is into
after
the
aneurysmatic part, yeah.
into aneurysmatic, yes, in the aneurysm. I post-dilated at 20 atmospheres with a semi-compliant 3O balloon. This part of vessel, okay, but nice. She's nice. So she's nice.
But what I see from here, you have some malposition distally that you are correcting now.
Yes, this is why I'm doing what I'm doing now. This is 2.5 balloon at higher pressure.
Yeah.
Just to
compliant
correct.
or non-compliant? This is the question. No, I'm joking. But what I think in this aneurysmatic part, probably this is something that should be left in this way because it is difficult to get a full opposition of the stent in this ectatic part. And it is not necessary because what I see here, you have an excellent minimal stented area, which is something for sure is a good sign for acute and events in the future. So I don't think it is necessary, and we have many studies that have proven that malposition, well, it's not good, but the main problem and the main what we are seeking is the minimal stented area, which is more than 8 millimeters.
Yeah, but there is a 0.8 malposition.
Yes, but I'm pretty sure you cannot correct this. Otherwise, there is a risk of rupturing the vessel because this is exactly part of the vessel here. Yes, there is some risk. There is some risk, and this is something that should be discussed with the patients for a longer do antiplatelet therapy because the risk of thrombosis of this part and of the vessel. But otherwise, I think it's reasonable to stop at some point. What do you think?
Hilal.
If you live in an aneurysm, was true at the time of BMS. We were standing across an aneurysm. We are not optimizing the stent in front of the aneurysm. But a bit for modern DES today, maybe it's different. But my opinion is what is favorizing the risk of stent thrombosis there will be to not to have an homogeneous diameter. If you have an homogeneous diameter crossing an aneurysm, if the diameter is sufficient compared with proximal and distal wall, I think will be okay. The risk is, for me, really moderate. If you follow the diameter of the aneurysm, then you will have turbulent flow there. And in my opinion, can be worse than not doing anything.
In a way, this stent is behaving as a flow diverter now. Probably it is not that big metal to artery ratio that it should have as a flow diverter in order to promote thrombosis of the aneurysm. Okay. But still, I think it is just reasonable to leave it like this.
Practically, even the malposition in the aneurysm the stent is open for sure more than 3 millimeters.
No, what I noticed is 8 millimeters minimal stented area, which is almost enough for the left main.
8.
8, yes.
Okay. So, this is where we are. Check some school. I just want to see here this.
And this malposition is only, let's say, in not a big circumference, Doris. So here it is more pronounced.
Yes, this is in the aneurysm,
but you cannot correct this, in my view. Or even it will be more dangerous for the rest of the vessel. Here you have a very good position of the stent. And how long is this segment?
It's practically no more than 5 millimeters.
Yeah. I think that's reasonable. More wise to leave it.
No more than 5 millimeters. Just to check. Okay, Eva.
You want to check something?
Yes. I just want to check the distal portion. At least this is here.
It's much better.
This is,
distal portion.
yes, definitely here we are just okay.
Here.
And
Where goes the
this,
calcium?
this is, yes, this calcium. Can you measure the vessel diameter and the stent area at this point?
At the distal part.
Yes. The vessel is not so small as it looks at the beginning, and yep, here, yes.
Here is
It's
Yes,
a
I know.
big vessel. It's a circ which is with a big marginal branch. But I think we have a pretty good result, and we should focus on the
Yeah.
Is 313.
yes.
This is distal.
Okay, can I ask for
Yes, this is
the
tissue.
2.5 non-compliant balloon?
Here, maybe.
And where is this part with
This
3.9?
3.13. It is distally above
yeah,
the
distal.
bifurcation.
I will make additional post dilation with the non-compliant 2.5 balloon just on the whole segment of the stent. Just to be sure that the stent is not underexpanded and to try to correct malposition. Just for the audience, underexpansion and malposition are two different issues. Just the first one, under expansion, means that the stent did not achieve the desired
So diameter.
vessel diameter or vessel area, and malposition means that there are struts which are not placed, did not laid over the vessel wall, and because sometimes there is some misunderstanding, advice. There is some misunderstanding regarding these two entities. Може ли таймера да ни го пуснете отново?
И не го спирайте.
И да не ми го... Okay, so we will make several inflations here. Just probably it was a wise idea to do this with the drag-coated balloon. Deflate.
I'm really happy to hear it, to hear
Nice.
this from you.
Sorry?
I'm happy to hear this from you.
Based only on the angiography, the result is quite good. But we should be, we should try to do the best. And the best to assess is to assess by intravascular imaging. Deflate. Advice.
Okay.
By the way, the question is, what about LED?
Ablations.
This or next session?
The opinion there is stage.
No, the mine is two, but I'd like to ask you. Okay. 22. 24. Unde?
Махам?
Да.
Така.
Yes, because the initial intention was to treat LAD, and the support from this Judkins catheter is not the best. For managing circumflex, yes. VII. Unde? VII.
This is 3 obalon or
2.5.
2.5? Non-compliant.
Non-compliant. Now it is non-compliant. I'm trying to correct the distal malposition. It is very short, very small segment, but I would like to do, okay, deflate. I would like to do the best for our patient. Okay, now it's good. Just let's make a picture. After these high pressure dilatations, I always check because with a small amount of contrast, just because I'm afraid of some extravasation. So we will do next IVUS. And probably we will stop at that stage.
Dobre,
Yes.
do you think you have an edge dissection on the proximal part of the stent?
Сега ще ти кажа като вида IVUS. Иначе си прав. Така изглежда.
Okay.
Okay. Дай ми имиджинг. Okay. Okay.
Can you have, yes.
So we have now,
Much better.
yes, the stent is now okay. This is maybe very, very short segment, and I think that the vessel is just eccentric at that point. I'm not sure that we will be able to correct this because it is possible that this is a calcium, some calcium into adventitia, and we will not be able to crack it. Just to see how it looks, the proximal part, the notion of Dr. Alexandrov.
It's excellent.
Yes, there is a small edge dissection, it's true. Eva, can you give me live again, image? Okay. 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 Yes, but this is really just very, very, very short.
That's a tiny dissection.
Yes.
No, but the circumference is not big enough, and we can see that the rear of the vessel is good enough. So I think this is
Yes.
in terms you can leave this dissection. I mean, what we have, because IVOS is one of the things that imaging that can rule out what to do with this dissection. Anyway, it is good to see it in on angio.
Yes, we will see it on NGO.
Another option, what I would propose, is to go for the left for the LED, but we have to remove the wire because of the, and after that wire again the circ while you're working with balloons and stents.
Да, да снимаме сега.
That's a good option too.
А може ли екраните маничко наляво?
Екраните може ли?
Да, мерси. Let's go. So, what the panel thinks?
I think it's a good and angiographic result. What was the minimum lumen area at the site of the dissection?
Let's see the ostium of the circumflex.
What we are thinking here is probably
Не, това е стент. Да, ето го тук.
here.
Да, ето.
Yes, exactly here, just to see the lumen area, and we'll be sure where it's.
The lumen, just measure. Lumen, just. Okay. No. Back. Още. Така. Още.
Between 7 and 5 o'clock, it should be a little bit.
So it is 5.6.
So it is above 4, so we don't have any issues with this.
5.6, I think that we can accept it.
And the sector of the dissection is less than, let's say, 30, it's around 30, 35 degrees, which is another sign, and the length is very short, so it's quite safe to leave it.
I just want to make one more projection about the circumflex. Okay, about the distal part. And yes, this aneurysm is around, which is uncovered, maybe it's around 5 millimeters.
I
How
don't
much?
think this will be a big issue.
10 millimeters. I don't know what else we can do. Actually, another option is to place, the only option actually at this point is just to place a graft stent. I'm not sure that this is a
Battery
Good-
enemy
good
of
option for the
no,
patient.
It is absolutely unjustified in my view, and we don't have evidence about this.
absolutely. There is no evidence that the patient will be better.
In fact, we have evidence that graft stents, even with the drug-eluting stents and drug-coated balloons, they are associated with a quite high number of restenosis and reocclusions. So that's
Actually, sometimes the nature help us, and the restenotic process just resolve these problems.
So the panel, part of the panel is gone. We were thinking what is going to happen now and how we are going to proceed. Shall we continue with the AOD? Probably we can postpone it for our next session. What do you think? Because we're much in time. I don't know what is the amount of contrast.
The contrast is 220.
Okay.
220, it is in the middle, but I'm not sure that I will be able to make an LED
Maybe we can wait to see
with
will be the Austrian circumflex and then manage the
I think it's a good option to postpone because we have just evaluated the right. We have done very good work on the circ, and probably LED is at least as much demanding as this circ, and there is nothing which urges us to go and to run for this this complex procedure. Definitely. Another point of view is that we have another area of, with troponin rise, because we know that the rotablation is paid off with some troponin rise because of the microcirculation.
Well, it depends. It depends.
Yeah.
But anyway, I think that to go into the third vessel with a complex procedure right now, mainly I'm really warning first about the contrast, and another issue, we are well with the fluoroscopic dose.
And how big is, what is the,
It's over there.
and the X-ray time and the,
The right corner.
Let me,
2 grays.
2 grays.
in the middle, yes.
Yes, we are actually at the middle. I don't know. Probably, I'm not convinced that it is very wise to
Our
to
proposal
continue.
is
Maybe
to postpone the AOD. I mean, not to postpone, but to do the AOD in the next session. Meanwhile, we are going to see what's happening with the circ, and that will be much more.
да направим една финална проекция.
It is really much more
Тя
wise.
порасна много.
It's a very good, very beautiful
Great
vessel,
result.
really.
Probably there was also some spasm at the ostium of the circumflex.
Yeah.
Now it's much better visible that probably there was some
There is a
spastic
plaque.
region, and we see just the point, distal point. There is aneurysm, but at least I see just before the bifurcation, the distal bifurcation of the circumflex. There is this small point of malposition, but I think that after inflation of 2.5 non-compliant balloon up to 24, 26
Yes, 24.
atmospheres, it is not, we cannot obtain much more with the current devices. So probably the best is to stop.
For sure. I think the result is excellent, and let's not forget that we cannot achieve this 5.5 square millimeters in all stents. Otherwise, we were going to work with 2.75 stent only, all vessels, which is not possible. So, congratulations.
Okay, thank you.
Really very didactic and very systematic work with an
Thank you.
excellent result.
Thank
And
you. And just to say about the yearly scientific meeting, which will be in April. This is for all colleagues, cardiologists and interventional cardiologists. I think it will be useful in April, so everybody are welcome.
So we are going to remind this tomorrow several times. And with this, we can put the end of this day. It was a long day, but hopefully, I believe, hope that you're on the same mind. It was quite successful and useful. Thank you.